Imagine a tiny butterfly-shaped gland nestled right there in your neck. It's quietly orchestrating this huge symphony of metabolic processes all through your body.
Sounds incredibly vital, right?
Oh, absolutely. It really is.
Well, today we're taking a deep dive into the fascinating world of the thyroid gland and its disorders. Our mission is to sort of unravel the complexities, give you the essential nuggets you need to understand, retain, and recall everything about this metabolic marvel.
And it's so important because this isn't just abstract biology.
No, not at all.
Thyroid disease affects, what, over 5% of people worldwide? And the really startling thing is that maybe half of those don't even know they have it.
Wow. Half undiagnosed. So for you, our future medical professionals listening, this truly is foundational knowledge.
Absolutely. And what's striking is just how profound its influence is. You mentioned metabolism, but its key roles stretch across development: the brain, liver, muscle, the cardiovascular system. Its impact is just incredibly widespread. It affects how we think, how our heart beats, our energy levels, everything. Okay, let's unpack that then. To really get a handle on its power, we need the basics first. Where is this metabolic butterfly exactly? What does it look like?
Right, so you'll find it in the anterior neck, low down, just in front of your larynx, your voice box, and the trachea, the windpipe.
Okay.
And it really does look like a butterfly. It's got two main lobes, the lateral lobes, like wings, connected by this central bit called the isthmus.
Ah, the isthmus.
Yeah, and it's incredibly vascular. I mean, it has one of the highest rates of blood flow per gram of tissue in the entire body. The busy place.
It's a busy place. I like that. And if we zoomed right in microscopically, what's going on there?
Okay. So the functional units are these structures called follicles. Picture like tiny spheres.
Okay.
Each follicle is lined by a single layer of cuboidal epithelial cells. And inside that sphere is this gel-like stuff called colloid.
Colloid, got it.
And the colloid is rich in a protein called thyroglobulin. That's basically the raw material, the scaffold for making thyroid hormones.
Okay.
And tucked between these follicles, you've also got other cells called parafollicular cells, or sometimes C cells.
C cells, what do they do?
They have a different job. They secrete calcitonin, which is a hormone that helps lower blood calcium levels. Kind of works opposite to parathyroid hormone.
Interesting. So it's not just sitting there, this gland. You mentioned it's busy, but it also has a story, right? How does it get there in the first place?
Yeah, what's fascinating is its journey during development. It actually starts forming really early, around week 4 of gestation.
Week 4?
Yep, as this little outpouching and endodermal pouch called the thyroid diverticulum right at the base of the tongue.
Base of the tongue, but it ends up in the neck.
Exactly. It has to descend. It travels down the neck, forming this temporary tube called the thyroglossal duct.
Okay.
Then the main part separates into the two lobes, and that duct, the thyroglossal duct, normally closes up and disappears between week 7 and 10. The gland itself becomes fully functional around week 12.
That's quite a migration. Does that journey ever go wrong?
It can, and that leads to anomalies we sometimes see clinically. For instance, if that thyroglossal duct doesn't completely disappear, you can get a thyroglossal cyst, often presents as a lump, usually right in the midline of the neck.
Okay, that makes sense.
Or you might find ectopic thyroid tissue. That just means thyroid tissue that ended up somewhere other than its normal spot.
Like where?
Well, about 90% of the time, it's found right back where it started at the base of the tongue.
No way.
Yep. And that can cause problems, potentially airway issues, infections, or even, though it's rare, malignancy later on.
Wow. Okay, so we know where it is, what it looks like, how it got there. But who's pulling the strings? Who's the conductor of this metabolic orchestra telling it when to play?
Ah, the conductor. That would be the hypothalamic pituitary thyroid axis. The HPT axis.
The HPT axis, okay, sounds important.
It is. It's this crucial feedback loop. Think of it like the control panel for your body's energy.
A control panel. I like that.
So the hypothalamus, deep in the brain, is like the master control. It sets the overall strategy.
Right.
Then the anterior pituitary gland, just below it, is like the mid-level manager. It gets orders from the hypothalamus and relays them down.
Okay, manager.
And the thyroid gland itself. That's the hard-working factory down in the neck, actually producing the goods, the hormones.
Master control manager factory. Got it. So how does the communication work?
It's a beautiful feedback system.
Yeah.
So let's say your levels of thyroid hormone in the blood drop too low.
Okay.
The hypothalamus senses this and releases a hormone called thyrotropin-releasing hormone, TRH.
TRH?
TRH travels just a short distance to the anterior pituitary and tells it, hey, release your hormone. So the pituitary releases thyroid-stimulating hormone, TSH.
TSH, that one I've heard of.
Right. TSH then travels through the bloodstream down to the thyroid factory. And TSH is the direct command. Make more hormones. And maybe grow a bit bigger too.
So TSH stimulates production and growth.
Exactly. And then crucially, as the thyroid releases more T3 and T4, and blood levels rise. Those higher hormone levels feed back to the hypothalamus and the pituitary and say, okay, levels are good now. You can stop sending TRH and TSH.
Ah, the negative feedback loop.
Precisely. It shuts down the stimulation, keeping everything nicely balanced most of the time.
That's an incredibly elegant system. But, okay, TSH tells the factory to work. How does the factory actually make the goods? How are these T3 and T4 hormones actually synthesized? Sounds complex.
It certainly is a multi-step process, and the absolute #1 requirement, you cannot make thyroid hormone without it, is elemental iodine.
Iodine. Okay, so like from diet.
Exactly. From diet, iodized salt, seafood, dairy. Without enough iodine, the whole process grinds to a halt. Now, to help you remember the synthesis steps, we can use a handy acronym, ISPOT.
ISPOT. Okay, I'm ready. What's the I?
I is for iodide uptake.
Right.
So iodine from your blood in the form of iodide ions. Needs to get into those follicular cells.
Right.
It's actively pumped in by a special transporter called the sodiumiodide symporter, or NIS. Think of it as a very busy gatekeeper on the cell membrane.
A gatekeeper.
Got it. Then, once inside the cell, the iodide needs to get into the colloid, that gel stuff in the middle. It does that via another transporter called pendrin, which swaps it for a chloride ion.
Okay, so I is getting iodine into the right place. What's S?
S is for synthesis of thyroglobulin, or T. Remember that big scaffold protein we mentioned?
Yeah, the one rich in tyrosine.
That's the one. It's made inside the follicular cell and then secreted out into the colloid. It's waiting there, ready to be decorated with iodine.
Okay, scaffold ready. Next is P.
P is for peroxidase, specifically the enzyme thyroid peroxidase, TPO. This is a really key player.
TPO, what does it do?
Its first job is to oxidize the iodide ions that came into the colloid into elemental iodine. This makes the iodine reactive, ready to attach to things.
Makes it reactive.
Yeah.
Okay, so that leads to O.
Exactly. O is for organification, or you could call it ionation. That reactive iodine, IO, now quickly binds onto the tyrosine residues on that big thyroglobulin scaffold.
Attaching to the scaffold.
Right. When one iodine attaches to a tyrosine, you get MIT monoiodotyrosine.
MIT.
If two iodines attach, you get DIT, diiodotyrosine.
MIT and DIT. Okay, we're almost there. T.
T's are for thiol coupling. This step is also catalyzed by that same enzyme, TPO.
TPO again. Busy enzyme.
Very busy. It takes these MITs and DITs that are attached to the thyroglobulin and couples them together.
Couples them. How?
So if a DIT couples with an MIT, you form T3 triiodothyronine. That's the really active hormone.
T3, the active one.
And if two DITs couple together, you form T4 tetraiodocyanine, or thyroxine. That's the more stable one, kind of like a prohormone.
T4, the prohormone. And these T3 and T4 are still attached to the thyroglobulin.
Yes. They're formed and stored right there on the TAG scaffold within the colloid. It's like a little hormone reservoir.
Okay, so ISPOT, iodide uptake, synthesis of TAG, peroxidase action, organification, and thiol coupling.
Got it. How do they get out into the blood?
Good question. When the TSH signal arrives.
From the pituitary manager. Right. TSH tells the follicular cell to reach into the colloid and engulf some of that thyroglobulin hormone complex.
Yeah.
It brings it inside via endocytosis.
Okay.
Inside the cell, lysosomes fuse with these vesicles, and enzymes chop up the thyroglobulin, releasing the finished T3 and T4 hormones.
Liberation.
And then those free T3 and T4 hormones can diffuse out of the cell and into the bloodstream to do their work.
Fascinating process. But you mentioned they get into the bloodstream. Do they just float around freely then? You said TSH signals for release?
Excellent point. No, they don't just float freely. And this is really important clinically. Why do you think that might be? And what does it mean for how active they are?
Well, hormones often travel bound to proteins, right? Maybe
Yeah.
they need help traveling, and maybe only the free ones can actually do anything.
Exactly. You've nailed it.
Yeah.
T3 and T4 are quite fat-soluble, or lipophilic. The bloodstream is watery, so they need chaperones.
Chaperone.
They mostly bind strongly to carrier proteins in the blood, mainly thyroxine-binding globulin, PBG, but also others like transthyretin and albumin.
So most of it is bound up.
Yes, the vast majority. And here's the key insight for you. Only the tiny fraction that is unbound or free is physiologically active.
Only the free T3 and free T4.
Correct. Think of the bound hormones like they're riding in limousines. They're being transported, they represent a reserve, but they can't get out and interact with the cells until they're free.
The limo metaphor. I like that. So when we measure levels in patients,
That's why measuring free T3 and free T4 often gives a much better picture of the patient's actual thyroid status than measuring the total amount, because total levels can be affected by changes in those binding proteins.
makes sense. And you mentioned T3 is the active one, T4 is the prohormone.
Right, T4 is produced in much larger quantities by the thyroid, and it's more stable, has a longer half-life, about 7 days. T3 is much more potent, maybe 3-4 times more active, but its half-life is shorter, only about 1.5 days.
So where does most of the active T3 come from?
A lot of it actually comes from peripheral conversion. Enzymes in tissues like the liver and kidney chop one iodine off T4 to convert it into the more active T3.
Ah, okay. And once T3 gets to a target cell, how does it work its magic?
So the free T3, or T4, but T3 is more potent, gets into the cell, often helped by specific transporters like MCT8.
MCT8.
Once inside, it travels to the nucleus and binds to specific thyroid hormone receptors. There are alpha and beta subtypes.
Nuclear receptors, so it affects DNA.
Precisely. T3 binding causes a conformational change in the receptor. This changed receptor can now bind to specific DNA sequences called hormone response elements, or HREs.
HREs.
And binding to those HREs either switches on or switches off the transcription of specific genes. That change in gene expression is what leads to all the downstream physiological effects.
Incredible. From the HPT axis signal down to changing gene expression. So what are those big downstream effects? What does this all mean for your body? What are the sweeping powers of these hormones?
They are incredibly wide-ranging. Let's start with metabolism. Thyroid hormones crank up your basal metabolic rate, your BMR.
Revving the engine.
Exactly. They increase thermogenesis, making you warmer. They stimulate processes that release energy, like gluconeogenesis, making new glucose, glycogenolysis, breaking down stored glucose, and lipolysis, breaking down fats. They even increase protein turnover, including muscle breakdown, and speed up carbohydrate absorption from your gut.
Wow. Metabolic powerhouse. What about the heart?
Big effects on the cardiovascular system. They increase heart rate, the force of contraction, cardiac output, and tend to raise systolic blood pressure. Part of this is by increasing the number of beta-adrenergic receptors on heart cells, making the heart more sensitive to adrenaline.
Makes sense. And development, you mentioned that earlier.
Oh, crucial. For growth and development, especially early in life, thyroid hormones are absolutely essential. They're needed for proper bone growth and mineralization, muscle development, and perhaps most importantly for the normal development of the brain and nervous system.
So a deficiency early on would be really bad.
Devastating. Severe deficiency in infancy and childhood leads to a condition historically called cretinism, now usually termed congenital hypothyroidism with developmental delay. It causes short stature and permanent severe intellectual disability.
That's why newborn screening is so important.
Absolutely vital. Every newborn should be screened so treatment can start immediately if needed.
Okay. What else? Neurologically, in adults.
Neurologically, they enhance alertness, wakefulness, memory, and speed up reflexes. Think about how you feel when you're hyper versus hypo.
Yeah, definitely. And reproduction.
Yep, reproductive health, too. They play what we call a permissive role for FSH and LH, the main reproductive hormones. Basically, ovulation often won't occur properly without adequate thyroid hormone levels.
So the takeaway really is, if a patient presents with a mix of symptoms, maybe they're tired, cold, gaining weight, but also maybe anxious or having heart palpitations or menstrual changes.
You absolutely have to consider the thyroid. Its effects are so broad it can mimic many other conditions or contribute to them.
Okay, with all that incredible influence in mind, let's test those diagnostic skills. Here's a scenario for you, our future doctors listening in.
All right, let's hear it.
A 34-year-old lady comes in. She's been feeling extremely anxious lately, very stressed. She also reports this funny sensation like her heart is pounding or fluttering in her chest, palpitations.
Okay, anxious palpitations.
She's also unintentionally lost weight, gone down 2 clothes sizes recently. Even though she says her appetite has been voracious, she's eating more but losing weight.
Weight loss with increased appetite. Interesting.
She was initially worried she might be pregnant because her periods have become irregular, but she's taken 3 home tests, all negative. And one more thing. Throughout the consultation, you notice she keeps rubbing her eyes like they're irritated.
Eye irritation, okay.
On examination, you feel her neck and find a goiter and enlarged thyroid gland. It feels diffusely enlarged, but it's not tender. So, based on that cluster of symptoms, what's the most likely diagnosis? Keep that one in mind. Mull it over. We'll come back to the answer after we talk about the common disorders.
Good case. Sets the scene nicely. So, when things go wrong, when that balance is off, we see thyroid disorders. And the first step in figuring things out is usually thyroid function tests, TFTs.
TFTs, so measuring TSH, T4, T3.
Typically, yes. Usually TSH and free T4 are the first line. Free T3 might be added, depending on the picture. And a critical first distinction we need to make is the problem primary or secondary?
Primary meaning the thyroid gland itself is the issue.
Exactly. The factory is malfunctioning. This is by far the most common scenario. Secondary means the thyroid gland is okay, but the pituitary manager isn't sending the right TSH signals.
Ah, okay. And how did the TFTs help distinguish that?
It's all about the feedback loop. In primary hypothyroidism, the thyroid isn't making enough hormone. The TSH level will be high because the pituitary is shouting, make more, but the free T4 will be low.
High TSH, low T4. Makes sense.
Conversely, in primary hyperthyroidism, the thyroid is making too much hormone. The TSH will be suppressed, very low because of that negative feedback, and the free T4 and or T3 will be high.
Low TSH, high T4, T3.
Oh, yeah.
Got it. And secondary.
In secondary hypothyroidism, the pituitary isn't making enough TSH, so both TSH and free T4 will be low. In the much rarer secondary hyperthyroidism, maybe due to a TSH-secreting pituitary tumor, both TSH and free T4, T3 would be inappropriately high.
Okay, that framework is helpful. Let's start with the sluggish snail scenario, hypothyroidism, when the factory slows down.
Right. Think of everything slowing down. The patient feels tired, sluggish, cold.
What usually causes this?
Well, in places with sufficient iodine intake, like most high-income countries, the most common cause by far is Hashimoto's thyroiditis.
Hashimoto's? That sounds autoimmune.
It is. It's an autoimmune disease where the body's own immune system attacks the thyroid gland. Specifically, antibodies, often anti-thyroid peroxidase or anti-TPO antibodies, target the gland, causing chronic inflammation and gradual destruction of the follicles.
Anti-TPO, targeting that key enzyme we talked about.
Exactly. It's much more common in women, typically presenting between ages 30 and 50. And patients often, though not always, develop a goiter, especially early on.
Okay, and worldwide?
Worldwide, the most common cause is still simply iodine deficiency. Not enough raw material for the factory.
Right. Any other major causes?
We absolutely have to mention congenital hypothyroidism, affecting newborns, about 1 in 2,000 here in the UK. It could be due to maternal iodine deficiency during pregnancy or problems with the baby's thyroid gland development, thyroid dysgenesis.
And we already know why that's critical to catch early.
Absolutely. That newborn screening saves lives and prevents lifelong disability.
So what are the classic symptoms you'd ask about for hypothyroidism?
You're looking for that slowdown, cold intolerance. They're always feeling cold when others are comfortable. Fatigue, lethargy, just feeling drained, depression or low mood, brain fog, difficulty concentrating, often weight gain, despite maybe not eating more, bradycardia, a slow heart rate, dry, coarse skin, maybe some hair loss, oedema, particularly puffiness around the eyes or face, constipation, and in women, heavy periods menorrhagia, and potentially a goiter.
Quite a list. Is there an extreme dangerous form?
Yes. It's rare, but myxoedema coma is a life-threatening emergency. It's profound, severe hypothyroidism leading to hypothermia, very low body temperature, severe bradycardia, low blood pressure, and significantly reduced consciousness, potentially coma. Needs urgent hospital treatment.
Okay, scary. But for typical hypothyroidism, what's the treatment?
Thankfully, treatment is usually very effective and straightforward. It's hormone replacement therapy with oral levothyroxine, which is just synthetic T4.
Synthetic T4, the pro-hormone.
Right. The body can then convert it to T3 as needed. It's cheap, widely available. The key thing for patients to remember is to take it consistently, usually once a day, and crucially, on an empty stomach.
Why empty stomach?
Absorption can be significantly reduced by food, calcium, iron supplements. So usually best taken about 30-60 minutes before breakfast, or sometimes at bedtime, several hours after the last meal.
Good practical tip. Okay, let's flip the coin. What about the overdrive race car? Hyperthyroidism.
Right, now everything is sped up. The body's burning through fuel way too fast. The patient feels wired, anxious, hot.
What's the most common culprit here?
Again, in most parts of the world, the most common cause, responsible for maybe 80% of cases, is Graves' disease.
Graves, another autoimmune one.
Yes, but this time it works differently. Instead of destroying the gland, the immune system produces antibodies that mimic TSH. They bind to the TSH receptor on the thyroid cells and constantly stimulate it.
So the factory gets non-stop on signals even when TSH is low.
Precisely. The pituitary is whispering, stop. But these antibodies are shouting, go, go, go. Like Hashimoto's, it's much more common in women.
And Graves has some specific signs, doesn't it? Beyond just the hyperthyroid
It
symptoms.
does. Look for the classic triad. 1, general symptoms of hyperthyroidism. 2, a diffuse goiter because the whole gland is being stimulated. And 3, sometimes specific eye signs known as thyroid eye disease or Graves' orbitopathy.
Ah, the eye signs, like exophthalmos.
Exactly. Exophthalmos is the bulging of the eyes. You can also see lid retraction, where the eyelids are pulled back, giving a staring appearance, and conjunctivitis, inflammation and redness. This is caused by inflammation and swelling in the tissues behind the eye.
Okay, so Graves is number one. What else causes hyperthyroidism?
You can have toxic multinodular goiter. Here, the thyroid develops lumps or nodules over time, and some of these nodules start producing thyroid hormone all by themselves, autonomously, ignoring the TSH signals. This tends to happen more in older individuals, often women, who might have had a simple goiter for years.
Nodules going rogue.
Kinda, yeah. And then there's de Quervain's thyroiditis, also called subacute thyroiditis. This is usually temporary hyperthyroidism.
Temporary. How?
It often follows a viral infection, like an upper respiratory tract infection. The virus seems to trigger inflammation in the thyroid gland, causing it to leak stored hormone. So you get a period of hyperthyroidism.
Ah, leaking hormone.
Right. Patients often have flu-like symptoms initially, maybe a fever, and typically a very painful, tender goiter. The hyperthyroid phase is usually followed by a brief hypothyroid phase as the gland recovers, and then it typically resolves completely on its own over weeks to months.
Painful goiter is a key feature there. So, symptoms of hyperthyroidism in general, the opposite of hypo.
Pretty much the mirror image. Heat intolerance, feeling hot, sweating easily, anxiety, nervousness, irritability, insomnia, unintentional weight loss. Often despite an increased appetite, they're burning calories like mad.
Okay.
Tachycardia, a fast heart rate, palpitations, a fine tremor, often noticeable in the hands, diarrhea or more frequent bowel movements. In women, periods might become lighter or stop altogether, oligomenorrhea or amenorrhea, and usually a goiter, though the type varies.
And is there an extreme emergency form here too?
Yes, and it's also very dangerous. Thyroid storm or thyrotoxic crisis. This is severe, life-threatening hyperthyroidism.
What does that look like?
Extreme symptoms. Very high fever, often over 40 degrees Celsius, very rapid heart rate, sometimes arrhythmias, nausea, vomiting, severe diarrhea, agitation, confusion, delirium, potentially coma. Blood pressure might be high initially, but can rapidly progress to shock and low blood pressure. It carries a very high mortality rate if not treated aggressively and quickly in hospital.
Frightening. How do you treat regular hyperthyroidism then?
There are a few main approaches. For rapid symptom relief, especially the palpitations and tremor, we often use beta blockers like propranolol.
Okay, symptom control.
Then to actually reduce hormone production, we use antithyroid drugs or thionamides. The main ones are carbimazole, which gets converted to methimazole, and propylthiouracil, or PTU. They work by inhibiting that key enzyme, TPO.
Blocking the ISPOT process.
Exactly. PTU has an additional benefit of also blocking the peripheral conversion of T4 to T3, which can be useful sometimes. These drugs are often used for a period, maybe 12, 18 months, hoping the condition, especially Graves', might go into remission.
And if it doesn't, or for other types?
Then we might consider more definitive treatment. Radioactive iodine ablation is common. The patient swallows a capsule of radioactive iodine. The thyroid gland eagerly takes it up.
Because it needs iodine.
Right. And the radiation then destroys the overactive thyroid cells over several weeks or months. It's very effective, but usually leads to permanent hypothyroidism afterwards, requiring lifelong levothyroxine.
So you trade hyper for hypo.
Often, yes. The other main option is surgery, a thyroidectomy, removing part or all of the thyroid gland. Again, this often leads to hypothyroidism. The choice depends on the specific cause, patient preference, severity, and other factors.
Lots of options there. Okay, armed with all that knowledge about hyperthyroidism, let's revisit our first case. The 34-year-old anxious lady with palpitations, weight loss despite huge appetite, irregular periods, eye irritation, and a diffuse non-tender goiter.
Right, putting it all together. The anxiety, the palpitations, the weight loss with increased appetite, the menstrual irregularity, those are classic hyperthyroid symptoms. The diffuse goiter fits, and the eye irritation really points towards
thyroid eye disease.
Exactly, suggesting early Graves' orbitopathy. So the most likely diagnosis fitting all those pieces is Graves' disease, the autoimmune condition causing hyperthyroidism.
Perfect. Okay, ready for another clinical puzzle?
Let's do it.
All right. A 54-year-old lady presents. Her main complaint is a lump she's noticed in her neck. She's also noticed that her voice has become quite raspy recently.
Neck lump and raspy voice. Okay, alarm bells?
She has a known history of Hashimoto's hypothyroidism and has been stable on levothyroxine for the past 6 years. But on further questioning, she mentions she's lost about 5 kilograms, maybe 11 pounds, over the last 2 months without trying.
Unexplained weight loss, too. History of Hashimoto's. Interesting combination.
On examination, you feel the lump. It feels firm, maybe hard, and seems fixed. It's non-mobile. Crucially, it doesn't move upwards when the patient swallows a sip of water, which thyroid glands and most thyroid nodules usually do.
Non-mobile lump. Doesn't move with swallowing. Raspy voice. Weight loss. Hashimoto's history. What are we thinking? We'll come back to that one, too. It brings us to another important topic.
Beyond just too much or too little hormone.
Right. We also have to consider thyroid malignancy or thyroid cancer.
Okay. What are the key signs or symptoms that should make you suspicious of cancer rather than just a benign goiter or nodule?
A distinct neck lump is often the first sign, but red flags suggesting malignancy include signs of invasion into nearby structures, like that raspy or hoarse voice, which could mean the recurrent laryngeal nerve is affected.
Nerve involvement.
Or difficulty swallowing, dysphagia, or breathing, maybe stridor, that high-pitched breathing sound suggesting pressure on the esophagus or trachea. A lump that feels very hard, is fixed to surrounding tissues, non-mobile, or grows rapidly is also concerning. Lymph node enlargement in the neck is another red flag.
And what about hormone levels? Would cancer cause hypo or hyper?
Interestingly, most thyroid cancers don't actually affect hormone production much. So the patient is often euthyr gator. Their TFTs might be completely normal. That's a really important point. Don't rule out cancer just because the TFTs are okay.
Good point. Are there different types of thyroid cancer?
Yes, several main types based on the cell of origin. The most common, by far, maybe 80%, is papillary carcinoma. It's generally slow-growing with a good prognosis, especially if caught early.
Papillary, most common.
Then there's follicular carcinoma,
Yeah.
the next most common. It can sometimes spread through the bloodstream. Medullary carcinoma arises from those parafollicular C cells we mentioned earlier.
The calcitonin-producing cells.
Exactly. It can sometimes be part of inherited genetic syndromes. Then there's anaplastic carcinoma, which is rare but very aggressive and has a poor prognosis. And finally, thyroid lymphoma, which is also relatively rare but is important to consider, especially in certain contexts.
Okay. How are they diagnosed?
Imaging is key, usually starting with an ultrasound of the neck. This helps characterize the nodule, its size, features like calcifications or irregular borders. Sometimes a radioiodine uptake scan is done. Cold nodules that don't take up iodine are statistically more likely to be malignant than hot nodules, although most cold nodules are still benign.
Ultrasound and maybe a scan. But definitive diagnosis.
Definitive diagnosis requires getting cells or tissue, usually via fine needle aspiration, FNA biopsy. A thin needle is guided into the nodule, often using ultrasound, to suck out some cells for microscopic examination. Sometimes a larger surgical biopsy is needed.
FNA biopsy. Okay, so let's go back to our second case. The 54-year-old lady with Hashimoto's presenting with a non-mobile neck lump, raspy voice, and weight loss.
Right. We have several red flags here. The non-mobile lump suggests fixation or invasion. The raspy voice strongly suggests recurrent laryngeal nerve involvement, another sign of invasion. Unexplained weight loss is always a concern for malignancy. And importantly, her history of Hashimoto's thyroiditis is a known risk factor specifically for developing primary thyroid lymphoma.
The Hashimoto's connection.
Exactly. While Hashimoto's primarily causes hypothyroidism, that chronic inflammation significantly increases the risk of lymphoma developing within the thyroid gland later on. Putting all those pieces together, the Hashimoto's history, the signs of invasion, the weight loss, the most likely diagnosis in this specific scenario is thyroid lymphoma.
Makes sense. A really important link to know. Are there any other thyroid conditions we should briefly mention?
Just a few quick ones to keep on your radar. We've talked about primary disease, but remember, secondary and tertiary thyroid disease exist problems starting in the pituitary or hypothalamus, respectively. They're much rarer, but important not to miss.
Pituitary or hypothalamus issues, got it.
Then there's sick euthyroid syndrome, sometimes called non-thyroidal illness syndrome. This is seen in patients who are critically ill from other causes like severe infection, trauma, major surgery.
Critically ill patients.
Their thyroid gland itself is usually fine, but their TFTs can become abnormal, often low T3, maybe low T4, and TSH in very severe illness. It's thought to be sort of an adaptive metabolic slowdown response to severe stress, not true thyroid disease. Interpreting TFTs in critically ill patients is tricky.
Okay.
You also hear about subclinical disease. This is where the TSH is outside the normal range, either high in subclinical hypo or low in subclinical hyper. But the actual free T4 and T3 levels are still within the normal range.
So just the TSH is off.
Right. It represents a milder form of dysfunction.
Mm.
Whether and when to treat subclinical disease is often debated and depends on the individual patient, the TSH level, symptoms, and risk factors. Often it just requires monitoring.
Okay. And one more.
One particularly notorious one is amiodarone-induced thyroid disease. Amiodarone is a very effective antiarrhythmic drug used for heart rhythm problems.
Right.
But it's loaded with iodine structurally. It's about 37% adenine by weight. And it has direct toxic effects on thyroid cells. Uniquely, amiodarone can cause both hypothyroidism and hyperthyroidism.
Oh.
It can cause hypothyroidism, partly due to the large iodine load inhibiting hormone release, the Wolff-Chaikoff effect, and also by inhibiting that crucial enzyme that converts T4 to T3 in the periphery.
Okay. Makes sense for hypo. How does it cause hyper?
It can cause two types of hyperthyroidism. Type 1 occurs in patients with underlying thyroid disease, like nodules, where the huge iodine load basically fuels excess hormone production. That's called the Jod-Basedow effect. Type 2 is actually a destructive thyroiditis caused by direct toxic effects of the drug, leading to leakage of stored hormone, similar to decurvains. Managing amiodarone thyroid issues is really challenging.
Wow. Sounds like a minefield. Good to be aware of.
Definitely one to remember if your patient is on that medication.
Phew. Okay. We have really covered a huge amount of ground today on our amazing butterfly gland. We went from its location and those tiny follicles through the whole HPT axis control system, the intricate ISPOT dance of hormone synthesis, how T3 and T4 travel and act, and then into the crucial signs of imbalance, hypo, hyper, and even malignancy with those case studies to tie it all together. I feel like you, our listeners, now have a really solid foundation for understanding this vital endocrine player.
I hope so.
Yeah.
And if we just step back and connect it to the bigger picture, the thyroid truly is a master regulator. It dictates the body's energy expenditure, influences growth, brain development. It's fundamental. Understanding its nuances, the common ways it can go wrong, and how we manage those disorders, it's absolutely core knowledge in medicine. And
Yeah.
applying that knowledge using critical thinking like we did with the cases, that's essential, especially when symptoms can be vague or overlap with so many other things.
Absolutely. It really requires putting those puzzle pieces together. So, here's a final provocative thought for you all to mull over as you continue your studies. Knowing just how profoundly the thyroid impacts nearly every single system in the body, what other, perhaps more subtle or seemingly unrelated symptoms might prompt you to consider a thyroid disorder in your future patients? Even if it's not the most obvious thing jumping out at first glance, maybe something like persistent dry skin, unexplained muscle aches, or even changes in mood or cognition that don't fit another pattern.
That's a great question to ponder. It really highlights the need to keep the thyroid in mind, to think broadly and connect those often subtle dots.